I'm presenting this talk on behalf of Dr. Johan Brink, who had nothing to disclose, and he was very happy to come to this meeting. He did a lot of the clinical work presented, and he did all the research, but unfortunately one of the family members of one of our staff is very sick, and so he had to stay behind, and that's why I'm giving the talk. He was very pissed. Had to cancel his flight just an hour before leaving. Not very good, and he's from South Africa, so he cannot restrain himself to put a picture of his hero in every one of his talk. And so we know the limitation of ECMO to bridge children, and especially small babies, to heart transplantation. We know that the field has completely changed since we had available the Berlin Heart. And just to give you an example, these three patients are less than 1 year old, 4 months, 7 and 8 months. They all were implanted within the last 4 weeks, and that picture was taken Monday this week, actually. But they're not in the study. So we are serving a population in Melbourne of about 25 million inhabitants, and we're the only centers doing pediatric heart transplantation and long-term VAD for this population. And we presented here the experience with the patients of less than 1 year old, because the reputation of support for these small patients has not always been very good so far, and our experience spanned from 2013 to 2018. So we have in Melbourne the experience about a bit more than 80 patients supported. We use different types of VAD, but for the smaller infants and children, we've used the Berlin Heart since 2008. And we had a crucial moment in 2013 when we started to support our first patient, which was less than 1 year old. That was just a newborn that we put on support. And that was successful, and that changed our indication, because up to that time we used not to support patients less than 1 year old, because we thought we would have no organ available for this patient. And you see that we've increased largely the number of patients supported since then. 8 patients between 5 years before 2013 and 34 since. And so that the total number of patients implanted who were less than 1 year of age at the time of the implant. So we had the experience with 14 patients, 4 of them neonates, less than a month of life, and all of them had biventricular circulation. We have not yet supported congenital heart disease and single ventricle. The diagnosis: 10 dilated cardiomyopathy, 1 patient with a LV non-compaction, 1 patient was born with coronary embolism and was really desperately sick. 2 patients had myocarditis and no congenital heart disease. So most of them were in Pedimax profile 3. Close to half of them were on ECMO before the implantation for a median of 9 days. Our cutoff is about 10 days now, a maximum of ECMO before we switch to Berlin Heart, and probably less, we've decided recently, for patients with neonatal myocarditis. 2 patients required resuscitation before implantation. 5 had LA or LV venting, and I had put required initially, but our experience we think now that we should probably vent more patients that we have actually had. And 4 patients had evidence of end organ damage. We talked about it, but they didn't seem to improve the end organ damage. They kept elevated creatinine and bilirubin even when they were placed on ECMO. So there was no BiVAD. The duration of support extended up to 252 days, and no patients were on support at the time of the completion of the study. 2 patients had a stroke, one of them fatal in a patient who had fulminant sepsis and initially myocarditis, and 1 recovered who actually recovered his heart function as well, and the device was taken out. So we had only 1 patient with a major fulminant sepsis responsible for the death of the patient. All the major infection fits the predefined criteria, but there were mainly bacteremia that were of not much consequences, and 2/3 of the patients need device change over the course of their support. These are our results of survival. 11 patients were successfully transplanted, 1 patient recovered, and the device was explanted, so that the survival was 86% in these less than 1 year old, And we had 2 deaths, 1 patient who died of fulminant sepsis and 1 patient who died of stroke. We don't have enough data with 14 patients to build up complex statistics to tell you the risk factor for mortality, but we can learn our lessons. So the patients we lost were 2 neonates with myocarditis. They both were on ECMO before being on support. They all had persisting end organ damage. These patients had a multisystemic disease. They were boggy edematous. They had liver dysfunction. They both need reintervention. One of the patients was support with an inadequate filling of the left VAD, which we thought was related to right heart failure, and we didn't dare to put a BiVAD at the stage. And finally, after 3 weeks, we found out that probably it was a problem of cannula position, which we changed, but too late, and the patient stroked. And the other patient was desperately sick again, and aortic valve regurgitation, which was repaired, but that ultimately failed, and he had fulminant sepsis. So we believe that one of the key elements of our success is that we're very picky about the cannula positions. You know the recommendation of Berlin Heart. The highest part of the bevel should be directed towards the free wall of the left ventricle, especially for these dilated cardiomyopathy. Otherwise, you have a suck down of this flaccid free wall. We do use this little extension with a piece of Dacron or a piece of Gore-Tex to the 5 and a 6 millimeter cannula. We secure it to the outflow graft first before putting into the aorta. But we think we need to be a bit flexible in these babies because the orientation of the chest is different than in adults. And sometimes if you put the bevel the way it's recommended, you have a suck down of the interventricular septum. So we have found situations where we have to put it in the exact opposite position. And that's the patients who ultimately died with the position before and the position after. And in some patients, with a cannula, it actually completely lifts up the heart. And in that situation, we had to put the highest portion of the bevel on the interventricular septum and a little bit on the anterior left ventricular wall. And that's the picture of it. But, some patients have a perfectly normal position of the cannula as recommended, and that functions very well. The only thing to know is that I think in small babies, small children, you have to adapt to your environment. And again, Johan is from South Africa and a hunter, so he has to put a picture of a lion somewhere. So in conclusion, the Berlin Heart EXCOR provided excellent support as a bridge to heart transplantation recovery, even in infants with dilated cardiomyopathy, not in neonatal myocarditis. We had a low incidence of neurological dysfunction. Myocarditis represents a very high-risk group, and we're still struggling to have survival in these patients. The optimal device function is mandatory with a low thresholds for early surgical revision. Nowadays, we don't hesitate at 24 hours. If we're not happy with the filling of the ventricle, we go back and change this cannula. And early durable VAD or ECMO may avoid the deleterious consequence of end organ damage and sepsis. And you will understand that when we look at these 3 kids that we have just implanted in the ward, our belief now in the Children's Hospital in Melbourne is that these 3 patients, now that they've been operated, they're in the ward and stable, we believe that they're almost guaranteed to survive without a stroke. That's our belief. And touch wood, I hope it's going to be fine. Thank you very much.
Well, thank you very much for excellent work and the presentation, sharing your experience. I have 2 questions. You mentioned you didn't include the patients with congenital heart disease or post-cardiotomy patients, single ventricle patients. Can you elucidate your criteria for the patient selection in this subset of patients? In particular, what's your management? What do you offer to these patients?
So you have to know a few things. So in Australia, we're dependent on a public health system, so we may look like we have resources, but it's a poor country when you talk about health, and so we have to look after how much we spend, and it's a very conservative country, so we make change progressively. So the first step was to prove that we could do patients less than 1 year old, and now with the quality of the results, I think we're ready to push the frontier to get to congenital heart disease patient and single ventricle. But it's a discussion that is taking place now. We haven't done that yet. So only myocarditis and cardiomyopathy for bridge to transplantations.
Excellent. So it's a work in progress, which you started now. Very good. The other question would be, you know, the waiting times in Europe are exceeding 1 year in most of the centers, especially in this group of patients under 1 year, and the mortality is still rising. I saw that you have one patient bridge to recovery. Do you develop in this your strategy some weaning protocol, and can you elucidate the possibilities to wean these patients? Do you have some criteria which you can share with us to offer these patients some different quality of life?
Yeah, so in patients that were older, we've been burned out at times above 1 year of age with myocarditis and recovery. I think that the lessons we've learned for recovery would be mainly for myocarditis in this age group. I think our cardiologists are very keen on having recovery. And so for older patients, we've removed some hardware in adolescent patients, 2 patients. So we focus on achieving recovery, and we have a protocol that I think we got from Edmonton for the Berlin Heart wean and some echo and cath studies at the time of the weaning process. The key things, I think, if you want to do that, is if you think that you're going to recover this heart, you should put the smallest of possible cannula. So if you have the choice between a 5 and a 6, in a 3 months old or a 4 months old, you should put a 5 because the 6 is quite bigger and it takes comparatively to a heartway to a adult with a cardiomyopathy, it takes a lot of space on the free wall of the left ventricle, and you amputate the surface of the ventricle quite a bit, and so we've been burned with a restrictive, creating a restrictive cardiomyopathy after support when you remove the cannula. So I think it's a dangerous thing to do with a Berlin heart. It's not impossible. We've done it, but it's a bit.
I have one question, if I may. So I think we published our results under 10 kilos something, or was it? I think it was around 10 kilos some years back, and I think many of the people sitting in the audience who have experience with Berlin heart will probably agree with me that the most devastating complication you can have is a thromboembolic event. And we see a lot of those, and probably at a higher incidence than you presented here, especially in this problematic group of patients in terms of anticoagulation. So what do you do differently in terms of anticoagulation that you don't see many of them?
So for anticoagulation, we put them, on when they're stable, we put them on warfarin and aspirin. We used to have dipyridamole, but now you use clopidogrel. The key of the success we have, I think, is the relationship with the team of hematology. The whole team of hematology is involved in the process. We have looked at our results carefully. The most dangerous period for us for thromboembolic events is the early period, and especially the time when you switch to heparin, from heparin to warfarin. The hematologists believe that at the time of the transition, initially, you are actually hypercoagulable when you start the warfarin, and so they crank up a little bit the heparin. In patients where we have issues, we have said that below 6 months of age, we would use a Clexane for maximum periods of 3 months, because beyond 3 months you have problems of bone demineralization. But the key element is their presence. We have a meeting on the bedsides every day the first week of implant, and as soon as they're stable, we have weekly meeting, and the hematologists are all in all the meetings. So it's testimony to their work.
William. Yeah, Bill Gaynor from Philadelphia. Very nice results, and I agree with Martin. We've seen a lot of thrombosis, and even here you had a lot of pump change-outs for thrombosis, even though you didn't have strokes. Based on the experience of others, we switched from heparin to bivalvulotin, and that's been very successful. I mean, much more stable and a much lower incidence of pump thrombosis. Do you have any experience with that?
We don't have yet any experience, but talk to me next week. I think we were just back from a Stanford meeting on heart failure and VAD, and the information I had 3 weeks ago is that 3 weeks ago there were 26 patients in the US on a Berlin heart, and 23 of them were on bivalirudin. So you put us in a very difficult situation, because if we have a stroke now, the patients will go on the internet, they're going to say, why was my baby not on bivalirudin? And so I think if you meet this success, the rest of the world will have no choice. They'll all be on bivalirudin. For me, there's no questions.
Thank you.
Thank you very much for practical information about the Lovato. And I'd like to have one quick question about the aortic valve regurgitation. So you commented about the aortic valve repair for the patient with aortic valve regurgitation together with the bearing heart. And which patient is the candidate for the aortic valve repair? And which type of repair did you choose for the patient?
So I personally didn't do the repair. So he had, I think if I remember, a triple subcommissural annuloplasty. That patient had a terrible myocarditis with a very important systemic reaction. I think that the thing that is not very clear in the public mind, and I've discussed it with Jibril El-Khoury, for example, and he agrees with me that if your heart is not working at all, normally you would think that the aortic valve function does not depend on the heart function. But if you really have a dead heart not functioning, you have annular dilatation of the aortic annulus, and you can have regurgitation. I've seen that a few times in my life. I think that you can be aggressive in this valve, knowing that these patients will never get to recovery and get a heart transplantation. Right. We should probably have done a cusp extension, but cusp extension are difficult on non-diseased native valves. I think that you have to sort out the way you can and do whatever you can, but we thought about doing a ROS in this patient, but it's
maybe it will be different depending on the consideration of the transplantation or not. Thank you very much.
Okay. One comment. You state that the myocarditis probably would be a complicating factor, but I have the chance to read the paper, and of course, but two of them, this patient, one had the problem that you explained about the cannula, the other one has the aortic regurg, and was the worst patient with high creatinine, high bilirubin, so probably would not be related essentially to myocarditis, but probably all these problems. Just to have your comment on this, we had the same problem with the cannula in the very small patients, but what we did is to convert from pulsatile to continuous flow valve. We removed the bearing heart, we put the electronics, because we strongly believe that the unloading of left ventricle in the continuous mode flow would be much better, at least in critical point. Then on chronic, you can go whatever you want, but at that time, it works for us. This just a comment, and then just to tell you, we of course are aware about the preliminary data from the United States on bivalve. That's why we shift to bivalve in the last 3 months. Now we use bivalve in all our bearing heart patients. Thank you very much. You are out of time. Thank you very much to everybody.